So ARDS is acute respiratory distress syndrome. It's caused by several things here in the corner. Okay, so pancreatitis can do it. That's one of the reasons we'll see it. Really bad pneumonia and a really bad surge response, such as like burns can lead to it as well. They have inhalation injuries can do it. So it's just damage to the lungs, and basically your body has gone haywire. It's like septic shock for the lungs, right? So your lungs have, septic shock is what's the word? An inappropriate response to inflammation. Your lungs have inappropriately responded, and they've gone haywire. The white blood cells have infiltrated, and they've caused pus to go throughout all the lungs. So all the lungs get damaged, right? And ARDS, every single alveoli are get filled with fluid and protein and pus, right? So obviously they cannot expand, right? So there's difficulty expanding. So that is a resistance problem or a compliance problem.
That's a resistance problem.
So resistance is the pushing of air into the into the upper airways, right? So this is a compliance problem. The lungs cannot comply. They cannot expand because there is all this stuff in the way, right, in the lower airways. Upper airway problems are resistance problems. So obviously we can't get a lot of tidal volume, right, because all that pressure is in the chest already, and if we start at like 5 a PEEP and we do 450 cc of tidal volume, that's going to be a lot of pressure compared to someone who has healthy lungs. So we want to have the tidal volumes on the lower side, okay? And we even do what's called permissive hypercapnia. Well, we'll allow the CO2 to get as high as we want, don't care, right? As long as the pH doesn't get too low. So pH starts getting like less than 7.25, less than 7.20, then we care. Then we'll start adjusting some things. But really our goal with ARDS is not to ventilate. Our job is to oxygenate. We want to get them oxygenated. We want the PO2 to rise, right? And there's only 2 ways to fix someone's PO2. And what are those 2 ways? PEEP and FiO2. And we know FiO2, that's more than 60% for more than 2 days, causes free radicals and ironically ARDS, right? So obviously we're going to get the FiO2 down to 60%, and everything else is all PEEP, baby. So it's all going to be all PEEP, right? All the way up to enough PEEP, right? So it could be 24, usually what most tables direct you to. So you get, because we have just these 2 things, PEEP and FiO2, to fix that oxygenation. And we'll allow permissive hypoxemia as well. We'll allow the PO2 to get all the way down to 50, right? It's like, oh, the PO2 is 60. I got to increase that FiO2 because my PEEP is 22. It's like, well, shoot, I'll allow 50 PO2 so that I can then, I can actually have them ventilated at a low FiO2, okay? So permissive hypercapnia, obviously, there's 2 things that raise the pressure in the chest, tidal volumes and PEEPs. If we really want to oxygenate with PEEPs, we got to sacrifice tidal volumes, right? So what's a normal tidal volume for any patient that's vented? Should be ideal. Is a good answer. Based on the idealness of the ideal patient. So yeah, so it should be 6 to 8 per kilo. Okay, so 6 to 8 mLs per kilo is a ideal tidal volume. So yeah, so ideal tidal volumes, 6 to 8 mLs per kilo, and then for ARDS, we'll accept all the way down to 4 mLs per kilo. We're going to bring it all the way down because we're going to sacrifice tidal volume in place of PEEP, right? So we want to make sure they are getting oxygenated. And yes, you can oxygenate a little bit with tidal volume because tidal volume has enriched oxygen in it, but we want to, we'll use PEEP more than anything else because the pressures are getting crazy high, right? So we have all these really high pressures occurring in the chest, right? These elevated plateau pressures, and these PIPs, plats are getting up to like 40, 45 and higher. So we want to, we're going to sacrifice tidal volume to make sure the PEEP is adequate. And also we talked about driving pressures, right? We get up to that high pressure, but we don't want to slam it all the way down to to make them have atelectasis. So this is driving pressure. We want less than 15. Okay, so plateau pressure is less than 30. PIPs will allow all the way to 45. Okay, tidal volume all the way down to 4. PEEPs, there's a PEEP table. I think I have the next page. So the PEEP is going to be all the way up to 24 if we need it. Okay. And going back to the tidal volumes, the tidal volume is super low. They get hypercapic. The pH starts going down. And so how can we fix that? If not, we can do what other maneuver to fix the high CO2s besides changing tidal volumes?
Change the inspiration, expiration.
You can change the IE ratio a little bit, but also you can change the respiratory rate, right? So the respiratory rate can be changed, right? We can increase it all the way up to 35 if we need to. So we can increase the respiratory rate if we need to. And then what else can happen if you increase the respiratory rate? Yeah, you could get auto peepings. We got to be alert to that. But sometimes your respiratory rate, the max respiratory rate you can have is usually 35 because of the air trapping. So if they are still acidotic, we can start giving bicarb drip. We're thinking outside the box, right? So bicarb drip is going to help neutralize, bring that pH a little bit. It's going to allow that CO2 to be 110, right? Because we don't care what it is as long as the pH is normalized. Okay, and then optimal PEEP. So again, PEEP is enough, up to 24 if we need to. And PEEP does not cause barotrauma. So there's a misnomer like, oh, I go too high in the PEEP, that's going to blow up my lungs. No, what causes the PEEP is your baseline. What the tidal volume on top of that, on top of PEEP at 20, let's say, you get 400 cc's of tidal volume on top of that. That 400 cc's is what's going to cause the barotrauma. Okay, so that's why we sacrifice the tidal volume. Okay. And then driving pressures we mentioned. So we'll talk a little bit more about driving pressures, but you want that less than 15. You don't want to have a lung that gets super, super big and then deflates. It's super, super big and then deflates. Super big and deflates. As it deflates, it causes damage and causes a surge response, and surge response causes inflammation, and inflammation at the source of where there is inflammation is going to worsen someone's ARDS. Okay. And then optimal oxygenation, we mentioned we allow permissive hypoxemia all the way down to 50, 55. And SATs 80 to 92%, sometimes all the way down to like 86%, right? Never hyperoxia, keep the FiO2 less than 60% if we need to. We can increase not the mean arterial pressure, but the MAP, like we mentioned, switching the IE ratios around, increasing, changing those guys around. And then in diuresing, like nobody's business. We're going to be dry lungs or happy lungs. So we're going to diurese aggressively. And if we diurese aggressively, we can start losing potassium. If we lose potassium, we get alkalotic. You get alkalotic, that can then, that can lead to some situations. So we want, sometimes we can add what's acetazolamide to acidify the blood to fix any kind of metabolic alkalosis that might be developing. Okay, and then neuromuscular blockade. So we have IV infusions of, we have our succinylcholine and rocuronium we talked about. Those are short-acting. We have long-acting agents like vecuronium or atracurium or cis-atracurium, right, which we'll talk about more in neuro and IV titrations. But these guys are used to paralyze the patient, take away all the oxygen demand that the lung muscles, the accessory muscles, are using, and then save that for the rest of the body, right? And you want to do it early. Sometimes, it's day 5 rounds. It's always like, why don't we paralyze them? Or so it should be, early. Once you identify someone in ARDS. So how do you know someone has ARDS? Their lungs have bilateral infiltrates. It looks like ground glass appearance. All the lungs bilaterally are full. And also, it's non-cardiogenic. So it means it wasn't the heart's fault. So you do a quick echo of the heart, and the heart's fine. And they have this pulmonary edema bilaterally. That's not from the heart. It's ARDS. Right? And the other piece is they have a PF ratio that's really, really low. We talked about PF ratio before, your PO2 divided by FiO2, and that PF ratio is really, really low, less than 150. There's different stages, 200, 150, 50, but when they're really, really low, that's considered ARDS. Okay, so our goal is, again, low tidal volume, increase your PEEP, take the fluids off, paralyze them early. Okay, so how much PEEP? Enough PEEP. You can see this patient right here has no PEEP, right? So yes, they have they're kind of recruiting, but look how I go all the way down to nothing, right? See, now they see they recruited the lungs a little bit. They recruited some alveoli, and then we bagged them up a little bit. See how they're kind of filling up some more. But look at the guy next door. We got PEEP. We've added like 5 PEEP, 10 of PEEP on there. Look at the alveolar recruitment comparatively. Look at this fluff up, right? Those are nice plump lungs that are easy to improve with PEEP. Okay, so here's PEEP right here. See these lungs nice and big, and we disconnect them, the lungs just deflate completely, right? See, all the air just leaves the lungs, and now it's really difficult to recruit those lungs. It can take up to like 1 to 2 hours sometimes to recruit really, really unhealthy lungs, right? And you can see this patient right here. Obviously, they're not alive. There's a cadaver, and you can see those lungs just filling up with air. Okay, and they're not even bagging the patient. All they're doing is providing nasal cannula. The apneic oxygenation I talked about with intubation is just a cannula going with a PEEP valve on top of it. So there's no bag valve mask action happening. All it is make sure you got a seal, make sure you got some PEEP, and the flow of oxygen is what's inflating those lungs. So that's the benefit of doing that while you're intubating. Okay. So ARDSnet, yeah, it is, but it illustrates that you have, the PEEP is important. Okay. So how much PEEP? So in the year 2000, they said, how much PEEP is enough PEEP. Okay. So make sure that you are maintaining good stats. We're not over distending, causing lack of flow to the lungs, and we're not, letting it crash all the way down to no PEEP, right? It should be somewhere nice in the sweet spot, in the middle right there. And that sweet spot is our driving pressure. And that's what you want, less than 15, okay? So it's your plateau pressure minus your PEEP. That is what a driving pressure is. So plateau pressure, let's say, is 30, and your PEEP is 14. That's a driving pressure of 16. That's okay. I'd rather increase my PEEP a little bit to get that on a driving pressure less than 15. That's going to prevent the atelectasis and the atelectic trauma. Okay. Avoid plats greater than 30. That's definitely going to cause problems, and if we need to get the PEEP up there, we're going to sacrifice tidal volumes in the meantime. All right. And SATs, again, we're adjusting PEEP and FiO2 with a goal FiO2 of 50 to 60%, and get that PEEP cranked all the way up. Here's this ARDSnet trial. You can say they went from 5 to 10 to 12 to 14, all the way up to 24 PEEP. Right? And as they did that, we can flip the IE ratio, we can paralyze them, and we can do some other strategies to help improve their oxygenation to get this FiO2 down from 100%, right? Because we know that that's also going to cause problems. Okay, so there's other strategies, kind of summaries. These are all posted at the station, each station, just so you have reference to what the PEEP tables are and what our goals are for every ARDS patient. So, I should be paralyzing. I should be doing this. I should be making sure my PO2 is all the way down to 50. CO2, don't care. I need a diuresis patient. So this has been summarized at each station as well for quick reference. All right. Remember the football? You're gonna start seeing your football start flying, falling down and deflating as your pressures start going down and down and down. So again, here's your driving pressures right here. Your plat minus your PEEP. That should be 15 or less, right? What should your PIPs be? Up top there, they should be no more than 45 in ARDS. 30 normally. Your plats should be no more than 30. Okay. And your PEEP is enough. Okay. So there's strategies that you can do. So besides inverting the IE ratio, besides paralyzing, besides diuresing, permissive hypercapnia, hypoxemia, we can also flip them over, right? So we recruit more lungs and expose the alveoli in the back of the lungs to oxygen for the first time. It's like a big light being shined or shown into these alveoli that haven't seen the light of day for a long time. Because when you ventilate, right, your lungs go upwards, right, and your diaphragm goes down a little bit. Most of your lungs tissue is all in the back here, and that's all going to fill up with fluid and pus and atelectasis and all this stuff that happens in ARDS. So if we flip them over, we can hopefully, yes, your diaphragm goes down, the front of the lungs may have suffered a little bit, but look at 2/3 of your lungs is all the way back here. That is what you're trying to ventilate. Also, you're ventilating it ergonomically, right? So your lungs are, when you are supine, your lungs look like this as you go in with the air. It has to like make a left turn, right turn. It has to open up, and it's all awkward, and it's going to cause damage to those alveoli as that high PEEPs and high volumes are going in with the high pressures. It's going to start damaging those lungs. So when we flip them over, it's just like a straight shot right to the alveolus. So it's a much easier, non-malaligned filling of the lungs. So it's a much easier, gentler way to fill your lungs. So that's another benefit of proning a patient, right? And when you prone them, again, you want to do it early, right? You don't want to be like day 10 and like, what can we do for this patient? And so on the back of the round, it's like, how about we prone? So it should be much, much earlier, right? Within 36 hours, once you identify they're in ARDS, right? You see a really horrible X-ray, you see a really horrible PO2 and PF ratio, it's time to prone them, right? And we have the power to do this. We have a mobility protocol. It's called progressive mobility, and it goes the other way. So instead of getting the patients out of bed, you go the other way and you flip them over, right? So we are allowed to do this as long as they meet criteria, okay? So PF ratio less than 150, right? Despite these high PEEPs and FiO2s, if it's less than 50, really you're kind of in ECMO territory. But all these things are prompted us more towards considering proning, okay, with ARDS patients especially. And then it allows the actin and mediastinum to unobstruct the lungs because you have the mediastinum in the way here. All the heart is now no longer in the way, right? It's now at the front of the chest and it can do its thing, and the lungs can now expand, right? Allows natural chest expansion, recruits alveoli that haven't seen the light of day in a second, okay? How long should it be? About 16 to 24 hours minimum, right? There is no maximum. You can have a patient prone for 7 days. There is no absolute maximum. It is just don't do it anything less than 16, right? Like at the beginning of COVID, like we prone patients like 6 times per year. At the beginning of COVID, we're like, let's do 6 on, 8 off, 6 on, 8 off. It's not beneficial. It needs to be at least 16, okay? So again, we just do it just kind of for families, and sometimes we want to do like procedures. We want to like supine them, get an X-ray, or we want to do like a dialysis for 4 hours. So let's go ahead and supine them while we get that done. Right? And when you do have them prone for 16 hours, you have to make sure you're turning them every 2 to 4 hours. You're flipping them back and forth. It's called the swimmer's position. I don't know if you ever laid in bed, you try to move your head the other way from where your hand is under the pillow. It doesn't work, right? So your muscles don't work that way. So you got to make sure they're always facing the arm that's up. Okay? Otherwise, it's like, I can't get this to work, right? So you have a swimmer's position, always looking, and then also you got to turn the head every 2 to 4 hours as well. You don't want pressure on the eyeball on the other side, right? Why? Because they're producing a lot of secretions, and it's also direct pressure on the eyeball. If you look at like like cervical spine cases, so in the OR, they're all about the eyes. Like, the eyes okay? Or how are the eyes? Are the eyes good? If you move the eyes, you water them. How are the eyes right now? So you got to make sure the eyes are good, because constant pressure, like 2 hours of pressure on the eyes, can cause permanent blindness. So we got to make sure the eyes are good. Now those eyes are now on the bed and full of secretions, and they're diabetic. Now you've created an area of fungus, right? And it's called mucormycosis, right? Where it eats through the brain and the skin and the bone all the way to the brain, and it's absolutely fatal. It's like an 80%, 90% mortality. So this is one of our real patients. So it's something that can literally eat through the brain. So we got to make sure we are churning the patient every 2 to 4 hours. Okay, so if they code, what happens if they code? What do? Do you flip them over? Nope, CPR in the back. And this is pre-COVID. It's well documented. Someone that's a spine case in the OR, you start doing compressions through the back, through the spine. Okay, because you can fix the spine, you can't fix anoxic encephalopathy from lack of perfusion to the brain, right? What are some contraindications to this? Are body habitus, BMI greater than 50, because you flip them over and their belly is super big, it's going to push up in the lungs, and it's not really going to help improve things. Okay, so this little tip sheet is on the ICU homepage. It's available to you. Kind of walk through how to prone a patient, right? There's some recommended strategies here to make sure we have good expansion of the lungs, little rolls to make sure on the shoulders and hips to make sure the lungs expand nicely. Right? You want to use the lift. Nobody likes to use it because you have to find the lift, you have to find the battery that works, but it's very, very easy. Once you have the patient on a canvas, you flip them back to supine the patient, you only need like 2 people. Otherwise, for a proning situation, especially your first time, it's a 6 to 8 person endeavor, right? You had proning schedules when we're proning like 6 patients, everybody had, okay, we're doing just like a proning crew, going all the way through the unit and just prone everybody. Yes? Proning beds, we do not have. We have these rotational beds. Those proning beds, we don't have those ones. So there's proning pillows you could buy as well. We did buy a little attachment to the head, so you can like bring the patient all the way up to the top of the bed and have their head hang off onto a little halo. But we don't have an official proning bed, no. Okay, so CLRT. So there's something called CRRT. It is not CRRT. All right, so CLRT, continuous lateral rotation therapy. Again, we'll touch base on this in our next lecture, but everybody that's in the ICU can mobilize, right? And everybody usually starts at 2. And who gets 1 where we are doing the proning here and where we're doing CLRT is someone who is sick, right? PF ratio less than 250, PEEPs greater than 10, SATs are low, respiratory rates high, heart rate and blood pressure are low. Then we're doing CLRT and proning. This is protocolized. There is a policy there that I wrote. I know it's there. So it's there as something that we can do as the RN. You're there. You assess them within 8 hours, right? You want to assess like what are we doing for this patient today or for my shift? Are we doing are we just getting the head up, bed up, and churning every 2 hours and trying to get get them in a chair by the end of my shift, or are they not going to tolerate that, and I'm going to go ahead and do some more rotational therapy, right? So we have 10 beds, 8 progressive beds and 2 sport beds that are like under house arrest that are that can do this rotational therapy, and also what's called a percussion and vibration therapy, right? So we can move all the secretions of the lungs and rotate them back and forth. That's going to help get the secretions loosened up and moved out and suctioned out. But also it's going to start training the baroreceptors in the brain and the carotid bodies, the aortic arch. It's going to get them used to, when they get better, to progress from one to the next, right? Because ideally everybody starts at level 2, and then if they do great, we go to level 3, where they start working on dangling the patient. You got PT/OT in there, but the baroreceptors are trash. They're not going to be able to sit up straight, right? They're going to sit up, or they're going to faint right back because their baroreceptors are not used to this, right? So we want to try to always maintain their mobility. Mobility has a lot of implications that we'll talk more next week with the ABCDF bundle, the E being early mobility. Okay, so within 8 hours, we want to make sure they are mobilized or identified, and we get something going by the end of our shift, definitely into the next shift, right? And then how do you know they need CLRT or proning? Again, that's the PF ratio and PEEP. They're not doing too hot. They look really sick. They're on 2 pressors. We can rotate someone that's on pressors. That's perfectly fine, right? And then how much rotation is it? So it's full max. You don't just like, oh, I'm going to do a super gentle, right? It's almost full throttle. The first time, of course, we're going to kind of rotate them into, or ease them into it. It's called the training mode down here. So you set as much rotation as possible, 1 minute one side, 1 minute the other side, 1 minute in the middle. You're going back and forth, and you want to do it at least 18 hours of the day, right? You don't want to just do it for like 4 hours, like, oh, there's your activity session. No, it needs to be at least 18 hours of the day to have benefit. And for the first time you do it, you train them. Every time after that, it's no training. So straight up, you're going right back into it, okay? Again, of course, while you're training them, you're always looking for, are their sats dropping more? Because when you move them, you're like using tissues that weren't usually used before. Okay, decreases VAP. It does all kinds of great stuff to improve outcomes. Improves length of stay, ICU length of stay. Gets them on the ventilator sooner. Avoids breakdown of the muscle, which is an important piece. Every day you lose about 10 to 14% of your muscle. If you're older, it's even higher. So we want to make sure that we are moving, mobilizing these the tissues in patients as much as possible. Okay, so again, if this is ineffective, then it's time for proning, right? Another thing to point out is sometimes people are like, oh, they're turning back and forth, so I don't need to turn them. It only moves the thorax, does not move the coccyx. So you still have to put a wedge under the coccyx. All right, so hypoxemia and ARDS. So what are our strategies? So tidal volume and respiratory rate. We can change those guys. Which one of those guys is going to increase the pressures in the chest? Tidal volume. So we're going to sacrifice tidal volume. How low are we going to get? Tidal volume all the way down to, because tidal volume, I thought I put it here, but it's 4 to 6 mLs per kilo, right? All the way down to 4 per kilo. We'll allow to get all the way down there. It's called permissive hypercapnia, right? So that will, yes, raise our CO2, but we have the respiratory rate we can adjust, right? We can get that all the way to 35 if we have to. So you can think of the P's to fix ARDS. PEEP, that's going to help improve oxygenation, right? So here's our oxygenation situation where we have PEEP improving. FiO2, yes, that'll improve oxygenation, but you want the FiO2 not to get too much in the high area. How high do you want FiO2 to be? Good, so less than 60%, right? So that's the ideal. And then we'll use PEEP to meet that. And we use these little PEEP tables down here. We used to use this other one where you had low PEEP, high FiO2, and the research came out and says, nope, that's not good, right? But the other stuff is still valid. We still want to crank that PEEP all the way up to 24 if we have to, even higher if we need to, but usually 24 is well accepted. Increase the PEEP, get the FiO2 to 60% or less. Target sats, 88%, even 86% sometimes. PO2 down to 50s, that's okay, right? And then another P is the P in diurese. Make sure they are fluid negative, right? That's our goal, right? Get 500 to 1 liter negative on our total balance. Paralyze them within 48 hours. Prone them if their PF is less than 150 within 36 hours, right? Rotate them, in the meantime. And then pulmonary vasodilators, so not a PRMC, has been in the works for like 1 to 2 years. So I think we're on the cusp of getting that ordered, where you get inhaled things that we're going to help our patients get more flow to the lungs. Because in ARDS, remember it's the body's protective mechanism to reroute blood away from areas that are hypoxic. It's like, don't go that way. Go the area where there is oxygen. But there's no oxygen in ARDS, right? All the lungs are filled up with fluid. So everything is vasoconstricted. There's no flow to the lungs. So if we improve the flow to the lungs, overall, we can improve oxygenation. And then you have VV ECMO, where you actually take the blood out of the heart, right? Out of the IVC, you oxygenate it and put it back in them, right? And that's usually when the PF is less than 50 to 70. You have to meet criteria too. Usually BMI, there are other comorbidities and such. Okay, so PEEP, paralysis, pulmonary vasodilators, proning, and perfusing them. These are all things that are going to improve outcomes in ARDS, right? So again, this only happens maybe 6 to 10 times a year at the most, but it's something to be aware of, and you can refer back to this. Every station has little recaps, so you know what to do if someone getting in a situation. But for the most part, we're just monitoring pips and plats, making sure they're not getting too high, and identifying if the pips and plats are getting too high. Are they biting on it? Are they having like an effusion? Are they having other problems? Worst case scenario, it keeps going up. The next day, it goes up more. Event settings are going up higher. You look at the X-rays, getting horrible. Now we're in ARDS territory, and then that's when you want to identify. Let's paralyze them or prone them and get them turned around.